Hi everyone, it is Christina Gerges. Welcome back to Psychiatry Network's Journal Club via Facebook Live. Tonight we have Dr. Craig Chepke who will be presenting our article on Ziprasidone. And there he is. He's very prompt and we are going to add him to the video. And sorry for the delay, guys. I had some toddler problems with bedtime tonight. I'm sure some of you can relate to that. Yeah, visiting grandmothers like to overindulge toddlers. That was really like the real problem. So I'm just waiting. Okay, I think we are good to go. And Dr. Chepke should be joining us in just one moment. Okay, it says it's adding him right now. Really, it's been a long time no see because we had a 2-week hiatus. And oh, hi, how's it going? Can you hear me?
Yes, I can hear you now.
Hi, perfect. Hi guys, I see we do have a few people watching already, and I was just apologizing for the delay because I just had some home issues. But everything's good now. And thank you, Dr. Chepke, for joining us. Tonight's article, maybe you want to, well, you know what? Why don't I introduce you formally and go through your bio. I ask all our speakers to send me a bio so I can introduce them and so you guys know who's presenting. And we just have so many accomplished people in our group. So I like to make sure everybody knows who our presenters are. So Dr. Chepke attended NYU School of Medicine and completed his psychiatry residency at Duke University, where he also completed his undergrad studies. He currently has a private practice in Huntersville, North Carolina. He also serves as a medical director for a level 3 residential treatment facility for adolescents and is an adjunct clinical professor of psychiatry in the University of North Carolina at Chapel Hill Medical School, precepting and instructing medical students and residents at the Atrium Health Charlotte campus. He has interests in treatment-resistant and severe persistent mental illness and patients with movement disorders. His research interests are in neuropsychiatry, and he is currently a principal investigator for trials on Parkinson's disease, psychosis, and narcolepsy. He went into psychiatry because it gives him the opportunity to apply the science of neurobiology and pharmacology to the art of understanding and interpreting human behavior to help others. He's been a member of Psychiatry Network since its inception in early 2016. He enjoys seeing what a cross-section of the field is thinking on certain topics and also likes to be able to provide feedback and education for peers. So again, thank you for joining us and for presenting this article, and I will let you take it away.
Thanks, Christina. And just so everyone in the audience knows, I'm not the toddler who she was referring to as the toddler shoes. So
that's right.
just wanted to
Yeah,
put that
I
one
have a
out
little
there for
guy here at
everybody.
home, so yeah.
So the paper that I'm going to be doing the journal club for tonight is Ziprasidone augmentation of escitalopram for major depressive disorder. So this is a randomized controlled, placebo-controlled trial. And it was done, so in terms of the authors and disclosures, there's about 7 authors or so, and a number of them did disclose that they had financial ties to Pfizer, who is the manufacturer of the branded Ziprasidone. Dr. Papakostas and Dr. Fava had research support and were consultants and speakers, and Dr. Bovo and Dr. Shelton were speakers and consultants as well. The trial was supported by a grant from the NIMH, and then also Forest Laboratories supplied escitalopram for the study, and Pfizer supplied the Ziprasidone. So the key questions that this article is trying this trial is trying to ascertain are, is adjunctive Ziprasidone when added to escitalopram effective for adults with major depressive disorder? And also, what's the tolerability of adjunctive Ziprasidone in the use adjunct for MDD? So in terms of the introduction of the paper, I think I can kind of sum it up by saying, why would we even care? Why are we interested if Ziprasidone would be useful in adjunct for treatment of MDD? For one, on a preclinical basis, the receptor profile of Ziprasidone is really kind of perfect for MDD. So if you're looking for an adjunct atypical antipsychotic, so it's got a partial agonism of 5-HT1A that's fairly strong, and an antagonism of 5-HT2A. But then also some of the lesser known serotonin receptors that also are postulated to contribute to antidepressant efficacy as well. As Ziprasidone has a good profile for serotonin 1B and 1D, which are important in the feedback loop that trying to stimulate it by serotonin from SSRIs. Antagonizing those receptors can help to continue the serotonin outflow. And also it works on the antagonism of serotonin 2C and 5-HT7, also which have been shown in some preclinical models to have antidepressant efficacy. Really, the only serotonin receptor that it doesn't work on that you would want it to on a theoretical basis is serotonin 3. So you've got a really good receptor profile for optimizing antidepressant efficacy with the Ziprasidone. There's also been some claims that it has a blockade of the serotonin transporter, norepinephrine transporter, even some claims made that it is comparable to that of imipramine or dizipramine. But there was a monotherapy trial with Ziprasidone that was a double-blind placebo-controlled trial, and it failed very badly. So it's not something that probably is going to be good enough to block the certain net on its own, but so that's why they're looking at it in conjunction with the Escitalopram. But why else would we care? Well, the other options that we've got that are FDA approved for treatment of major depressive disorder are ones that have some significant side effect burdens, metabolically, in terms of sedation, activation. So Ziprasidone, as we probably know, has a low propensity for metabolic side effects. Also, in terms of inter-subject variability, its metabolism is about 2/3 by aldehyde oxidase and only 1/3 by cytochrome 3A4. So there's very low chance for genetic polymorphisms or also drug-drug interactions that would cause significant variability between patients with Ziprasidone. And also, since March of 2012, it's generic. So all this adds up to be a potentially very interesting treatment in adjunct to at least one SSRI, escitalopram, in major depression. So getting into the study itself, so it was conducted at 3 academic medical centers, Harvard, UAB, and Vanderbilt, and it was done over about a 5-year period from 2008 to 2013. So they started off they had 2 phases of the trial. Well, first, actually, let me talk about the inclusion criteria. So they included patients between the ages of 18 to 65, and they all had to have a primary diagnosis of major depressive disorder, according to DSM-4, and then confirmed it with the SCID. And to gain entry into the trial, they had to be acutely depressed with the QIDS, Quick Inventory of Depressive Symptomatology, greater than a 10, and the exclusion criteria: anyone high risk for safety reasons, suicide, homicide, unstable medical conditions, anybody who had previously been treated in the current episode of MDD with escitalopram, or any history of ever lifetime trial of Ziprasidone. And also patients who are too severely treatment resistant, having failed more than 3 adequate trials of antidepressants in the current episode to give it a fair chance. That's a fairly common exclusion criteria in pretty much all MDD trials. So the study procedure itself, the phase 1, they had the patients given escitalopram starting at 10 milligrams daily, and over the first 8 weeks, the study investigators were able to titrate that to 20 or 30 milligrams on a weekly basis as deemed necessary. And then, after week 4, they had to remain stable for the rest of the trial on that dose of the escitalopram. So there were some, in the paper, there were some concomitant psych meds which were allowed. We won't go into that for time reasons. And then, so after 8 weeks, they were assessed for continuing depressive symptomatology. And if they continue to meet criteria for a major depressive episode by DSM-4, and also had not responded by the Hamilton ratings, the Hamilton 17 depressive rating scale, or the QIDS, then those non-responders would be enrolled into phase 2, where they were augmented with the escitalopram. So there were the primary outcome measure that they were looking for in this study was the Hamilton D Depression Rating Scale, a response which was defined as greater 50% reduction on the HAM-D. And then there were some secondary outcomes that they looked at too, which were pretty interesting. They looked at anxiety with the Hamilton Anxiety Rating Scale. And then also, as I mentioned, that there's some theories that the ziprasidone could have norepinephrine reuptake inhibition. That they looked at the visual analog scale for pain to see if it could have some benefits for pain, similar to duloxetine or some other SNRIs as a secondary outcome measure a priori. So kind of skip past a little bit. I could end up talking for hours on just about anything. So to make it fit in 15 minutes, I'm going to skip past a couple things. The average dose of the escitalopram by the end of the study was about 20 milligrams in each treatment arm. And then the average dose of ziprasidone that the patients ended up on at the end of the study was about 98 milligrams, mean daily dose. They had 20 milligram capsules that were blinded, and for both placebo and for ziprasidone. And the patients were started on 20 milligrams twice and instructed to take it twice daily with a meal. So it was hopefully administered properly to themselves, that they were able to get the full bioavailability. Of course, one of the caveats of ziprasidone is that you need to take it with at least 350 or so calories in order to get good bioavailability. So that was ensured in the trial, the best they were able to do. And so they ended up with about 98 milligrams a day, so about 100 milligrams a day average daily doses of ziprasidone in the treatment arm. So how did it work? So the patients who completed the phase 2, there were 69% of the patients in ziprasidone group completed the phase 2, and 77.9 in the placebo group. So were able to finish the trial. So it was a few more dropouts, but actually not a statistically significant difference between those two groups. But numerically, more patients dropped out on ziprasidone. And no patients, though, dropped out of the escitalopram group due to an intolerability reason, whereas about 14% of patients in the ziprasidone group, their reason for discontinuation was due to adverse reactions. So how did it work? In the Hamilton D, there was a response of 35.2% versus 20.5%, which was significant statistically. So a 15% greater number of patients were able to achieve a response on the HAM-D with ziprasidone. So to put that into some other terms, because those kind of statistics never really give me an idea of how well it's actually working, looking at effect size. A standardized effect size with Hedges G was a 0.53. So for comparison, typically antidepressant effect sizes in clinical trials is about a 0.3 or so, as being a low effect size, small effect size. 0.5, that range would be a moderate effect size, and 0.7 and above would be a large effect. So it had a fairly, we would put it at a moderate effect size, but this wasn't in this paper, but just for educational purposes, I pulled up effect sizes from other adjunct MDD trials with atypicals. And from a meta-analysis that was done in 2013 of all the trials of the different drugs, aripiprazole had a effect size of 0.35, so smaller than ziprasidone. Quetiapine in their 3 clinical trials was 0.4. There's 3 risperidone trials as adjunct for MDD, that's 0.48. So the average for, and then for the olanzapine fluoxetine combination, fixed dose combination, effect size was 0.26. So ziprasidone actually had a larger effect size than any of the FDA-approved treatments for MDD. Brexpiprazole also, theirs was 0.23. So
were those trials also with escitalopram or other SSRIs?
No, not that's one of the things that's kind of unique about this trial, is that this was restricted to just escitalopram, which the authors did not discuss why they made that decision. An idea I had was that, to me, I think escitalopram was probably the best of the SSRIs, so They just wanted to standardize on one, but all the other trials did use the olanzapine fluoxetine combination pill. Obviously, that was only fluoxetine, but the others they had a mix of different antidepressant SSRIs.
Okay.
So not exactly directly comparable, but
Still good.
across different methodologies somewhat. But and this is only one trial versus between 3 to 5 for the other drugs. But just to give you a ballpark, this is something that in terms of effect size, there's some suggestion it could compare favorably. Also, number needed to treat for ziprasidone is 7, and the average across the other atypicals is the number needed to treat of 9. So lower number and number needed to treat is more favorable to the drug. Again, multiple studies versus just one, but there's some fairly decent evidence in this trial that it could be efficacious for MDD. So the secondary outcome measures for anxiety, that was actually I thought very surprising. It had very robust effect on anxiety. 30% of patients had a response on the HAM-A versus a 13%, which gives an effect size of 0.36 and number needed to treat of 4. So only 4 patients need to be treated with adjunct ziprasidone to get a response on the Hamilton A for anxiety symptoms versus response with placebo. The visual analog scale for pain did not separate from placebo, not even close. So that theory failed that there would be any significant improvement in pain, but it did statistically separate on both the depression primary outcome and a key secondary outcome of the Hamilton A for anxiety. And adverse events, obviously very important with adjunct antipsychotics. I think most people in the group would agree that we all kind of know that adjunct atypicals are effective for depression, but they come with a fairly heavy hand of side effect burden. So how did ziprasidone measure up? So in terms of discontinuation due to adverse effects, there was number needed to harm of 10. So it took treatment of 10 patients to see 1 dropout. The side effects which occurred at greater than 5% and double or greater than double the placebo rate would be somnolence, which was 33 versus 11%, number needed to harm about 5. So quite a few patients getting sedated, even though very little antihistamine receptor binding with ziprasidone. Irritability was about 10% versus 1.5%. Anxiety, agitation, 6% versus 0, and muscle twitching, 11 versus 7.5%. So the scores for akathisia, there was not statistically significant placebo versus the ziprasidone group, and GI upset was close to significance, but not quite significant. Again, not in this paper, but I looked it up for educational purposes, looking at the bipolar disorder pivotal trials for ziprasidone. And the side effect profile is actually a little bit worse in this trial for these patients. More common for there to be discontinuations. Number needed to harm in the bipolar trials was 35 versus 10 here. And then somnolence, number needed to harm 4.5 in this trial versus 5.3. So you did see a few more side effects in this population of depressed patients. So we often see with atypicals that the side effect burden is different from the schizophrenia trials to, if there are bipolar trials, to MDD, and we do see that as well. That different mood disorder diagnoses can confer that population could have a different side effect profile potentially. One of the questions not answered in this paper, but there was a follow-up paper done 2 years later that was released on the same clinical trial, looking at the cardiac side effects of the patients in trial. Because when you're talking escitalopram and ziprasidone, who doesn't think QTC immediately? That was very surprising not to be in the original paper, but so fortunately they did address that in a follow-up paper. And so there was a trend towards a significantly greater QTC, but it was not statistically significant. The p-value was 0.06. So presumably that's why they didn't put it in the first paper, but I think that's a pretty glaring omission that that's going to be a question on everybody's mind. The QTC increase numerically in the trials was 8.8 milliseconds. But again, that was not statistically significant in the treatment group versus the placebo group, which was receiving only continuation of escitalopram and placebo. And there was a slight increase in weight gain. It was about, let's see, 2.5 kilograms, so about 5.5 pounds. So not a trivial amount of weight gain, and again, that's a little bit more than in the bipolar trials. So possibly the patients with depression might be a little bit more susceptible to weight gain, is what that kind of suggests. So in terms of the discussion of the trial, I think the strengths of it are that it's to date the only double-blind placebo-controlled trial of Ziprasidone as an adjunct for MDD. The monotherapy trial, as I mentioned, failed pretty badly, and there were some open-label trials of Ziprasidone with SSRIs, not restricted to just Escitalopram like this one was, but that one also did not, as an open-label trial, was suggestive of possible benefit, but nothing could be proven statistically, obviously. So having a large, and this was a fairly large trial with the number of patients treated similar to what we would see in a registration trial for by a pharmaceutical company, and was conducted kind of similarly to what we would expect that we would see as a pivotal trial for potential FDA registration. Although this, again, this was not sponsored by the manufacturer. This was investigator initiated, primarily funded by the NIMH, but with free product supplied by the manufacturer. So that was, I think, the big strength of the trial. Weaknesses, the inclusion criteria. For one, it was only academic medical centers, which not all of us work in academic medical centers. I definitely, and I saw Dr. Shirey logged on. Hey, Kristen. Our population in residency is, for me at least, was quite a bit different from what I see out in the field away from academia. So applicability to the broader patient population could be limited. And then exclusion criteria as well. Anyone who was already in the major depressive episode taking an antidepressant or an antipsychotic was not eligible. So they could not be directly switched. They had to be off treatment altogether, which is often fairly unusual for the patients that we would see. And then, again, for the very treatment-resistant patients, if they had failed more than 3 or more antidepressants in the current episode. So there were a number of exclusion criteria, but nothing too onerous, I'd say, compared to what we're used to from these kind of large trials. So take-home points, how it could affect your practice. What got me interested in wanting to present this article was that about 2 years ago, a local psychiatrist in my area who was towards the end of his career actually retired and sent a very large, many dozen patients over to my clinic. And he had a number of patients with MDD on Ziprasidone. And I thought that was very interesting, but they were all, the ones who made it to me were doing very well with it. And so
on monotherapy or
no,
combination?
They were adjunct to various SSRIs and SNRIs.
Interesting.
But yeah, it was a surprisingly large number. And I had not 2 years ago was this paper was just only out came out in 2015. So I had not seen it, and I thought this would be a fun one to dig into and see what the evidence base is for it. So take-home points is that it was shown to be that the results here suggest that it could be efficacious with a fairly decent effect size and a fairly small number needed to treat, and that it had in this trial fairly robust results for anxiety, and the tolerability of it. While still fairly significant tolerability issues, there are some advantages versus aripiprazole versus quetiapine, and it's inexpensive. I looked it up on GoodRx, and it's $40-50 a month, no insurance, cash with a GoodRx coupon. So that's quite a bit less expensive than many of the other atypicals, even or comparable to the generic ones, and quite a bit less than the currently branded ones. So it could be a potentially good option for patients that were looking to treat the resistant major depressive episodes with atypicals, as opposed to some of the other options that are FDA approved.
Well, thank you for that succinct and but thorough explanation of the article tonight. If anybody has any questions, feel free to post them in the next minute or so. Otherwise, we'll wrap up shortly. Thank you again, Craig. And just as a reminder to everybody, if you're just watching this and you haven't watched any of our Journal Club Facebook Live videos, this is a series that we're doing every Monday and Wednesday. Starting next week, we'll be back on our regular schedule every Monday and Wednesday at 7:30 p.m. Central Time. The schedule is posted in the group under the Units tab. By the way, that's a new tab that we have. We have a bunch of other tabs, but the Units tab, it's like a learning module. So I put all the articles, I uploaded all the articles and put the schedule there. And of course, the other way to get the schedule ongoing is through our mailing list. Please email me at psychiatrynetwork@gmail.com if you're not on the mailing list and want to be added. And we do have several people thanking you. So I don't know if you know them or not, but
I don't. So this is really
okay.
flattering. Thanks
Yeah.
everyone for your attention. I appreciate it.
Yeah, and thank you again for your time. I'm very appreciative of all the people who have volunteered to do these videos because, I mean, really, this is a group community, and we wouldn't, we really wouldn't have all these things to share together without each other's input. So I appreciate the time that all the individuals have put into it. So, and thank you. I mean, you presented the article, but you also did all this extra research, which is appreciated. So. And you have an NYU alumni, it looks like, also
all
waving
right.
hi.
Go
So,
Violets.
yeah. All right. Well, guys, thanks for watching. And you can claim the CME. The link is in the top of the post. And you can always watch this later, too, again, if you want to. And just answer the 3 questions that come up for the CME. And you will be able to get 0.25 credits for each video that you watch. All right. Have a good night, guys. Thanks
Happy
again,
New Year,
Craig.
everybody.
Bye.
Bye.
Happy New Year.